We hope you enjoy this webinar. A reminder that this webinar is being recorded and we refer you to the disclaimer information that will have accompanied your registration, and which can be found at the address below. The agenda for today's webinar will be as follows. The keynote speech is the Global Action Plan on Neurology and Epilepsy by the World Health Organization. Then we will present initial results from the EMEA survey of patients in Europe that was carried out in 2021. Of the many issues with regard to ME, CFS, the standardization, consistency and collation of data is one area lacking in Europe. We will hear of a platform that possibly already provides everything required to monitor ME, CFS. A model clinic for severely affected ME, CFS patients will be described using actual experience. In these times of the pandemic, then this meeting will also include discussions on the similarities between long COVID and ME, CFS, with feedback from a recent major international study that looked at long COVID in 17 countries. Today we are pleased to welcome attendees from at least 19 countries for this webinar. We welcome our invited panelists today, from EMEA, EFNA, European ME Research Group, NIH, CDC and other NGOs and healthcare agencies. These panel sessions will be led by EMEA. In November 2020, the 73rd World Health Assembly adopted Resolution WHA 73.10 on global actions on epilepsy and other neurological disorders, which requested the WHO Director General to develop an intersectoral global action plan on epilepsy and other neurological disorders in consultation with member states. Following EMEA, EFNA's first roundtable in the summer of 2021, that was opened with Dr. Tedros's speech, we were contacted by Dr. Tedros' office. They said that many of the topics discussed at our roundtable, i.e. the challenges faced by those suffering and their families, improving access to care and support, improving education, information, bottlenecks in research, treatment and services, are addressed and included in the WHO plan. In light of the steady progress being made with the plan, Dr. Tedros had requested that WHO engage with EMEA to arrange a presentation on the draft action plan at our next International Roundtable meeting. We are, therefore, pleased to welcome Dr. Deborah Kestel, from the WHO's Universal Health Coverage, Communicable and Non-Communicable Diseases Department that carried responsibility for the plan, and so we welcome Deborah to present the keynote speech today on this topic. Over to you, Deborah.
Thank you very much for this opportunity. I will share my screen, if that is okay. Let's see if it works. And please confirm that you see the slide.
Yes, that's fine.
Thank you. So, I will again thank you for this opportunity to be here with you today and to present what it is that we do in the World Health Organization in the area of neurological disorders and brain health, and the draft intersectoral global action plan. So hopefully you see this moving. Under neurological disorders, we mean conditions of the central and peripheral nervous system that include those listed in this slide. Neuroinfections and neuroimmunological disorders, traumatic brain and spinal cord injuries, epilepsy, headache disorders, neurodegenerative disorders, cerebrovascular disease, including stroke, and neurodevelopmental disorders. Globally, neurological disorders are the leading cause of disability-adjusted life years and the second leading cause of death. And the burden is high in low and middle-income countries where most of the world populations live. A contribution to these numbers, unfortunately, is the insufficiency of services and support for neurological disorders in most low and middle income countries. For example, only 1 in 10 with dementia receive a diagnosis, and only 1 in 4 people with epilepsy, a disease which is treatable in 3/4 of people, receive any treatment. Supplies of cost-effective medicine are also insufficient. In one in 3 countries have the most common medications for Parkinson's disease at primary healthcare level. The same applies to the specialists working with neurological disorders. While high-income countries have 7 specialists per 100,000 populations, low and middle-income countries have only 1 per million. Everywhere, they are mostly in concentrated in large cities. And there is widespread lack of knowledge about neurological disorders and high levels of stigma and discrimination, which reflects on people with neurological disorders. So all this gives us sufficient reason to emphasize, increase and multiply the work in this field. And in order to raise the priority, WHO has a dedicated unit for brain health in our department. The vision of the unit is to promote optimal brain development, cognitive health and well-being for all across the life course. And to achieve this vision, the Brain Health Unit has 4 main objectives that you have again in the slide. The first one, to strengthen policies, service delivery, health information systems, technology, research, and innovation for brain health. The second one is to provide technical assistance and guidance on how to formulate an integrated approach to brain health using promotion, prevention, treatment, care, and rehabilitation. Next one is to foster increased investment and interagency collaboration across sectors. And last but not least, to work globally and at country level for more impact. Our integrated approach is to consider neurological disorders in a continuum from promotion and prevention to diagnosis and treatment and rehabilitation. And in addressing this, we also consider comorbidities such as mental health conditions, communicable and non-communicable diseases, and we also pay attention to the social determinants of health. Neurological disorders are considered across the life course throughout the whole health and social care systems and are at the primary care level with emphasis on universal health coverage. To maximize impact and to promote this integrative approach, we have been working on the forthcoming intersectoral global action plan and brain health position paper. On this slide, you see a number of examples, activities that the Brain Health Unit undertakes, which are very diverse, from complete programs on very widespread conditions such as epilepsy and dementia, to paying attention to the neurodevelopment and brain health of children and adolescents. And we also work in service delivery and access to medicines and on monitoring and research. And as you know, the pandemic of COVID-19 also required the unit to contribute to organization-wide response. Now, let me update you on the upcoming Global Action Plan on Epilepsy and other neurological disorders in 2020. As it was mentioned, the World Health Assembly asked the Director General, Dr. Tedros, to develop and submit to the 150th Executive Board a draft 10-year intersectoral global action plan on epilepsy and other neurological disorders. And in the development process that we were actively working to collect feedback from as many stakeholders as possible, including member states, United Nations agencies, and non-state actors, civil society, including people with lived experience, academic institutions, private sector. The invitation to contribute was posted online, so people, whoever was interested had the opportunity to contribute to that. So we had a lot of inputs first on the discussion paper that we developed, and then on the first draft of the action plan, which we have included when refining each step, each draft. We are happy to say that the Executive Board 150 discussed the Intersectoral Global Action Plan on Epilepsy and Other Neurological Disorders 2022-2031, and recommended that it's to be adopted by the 75th World Health Assembly, which is taking place in a few weeks towards the end of May. So fingers crossed for that approval. So what is in the plan? First, the vision of the action plan is a world in which brain health is valued, promoted, and protected across the life course. Neurological disorders are prevented, diagnosed, and treated, and premature mortality and morbidity are avoided. People affected by neurological disorders and their carers attain the highest possible level of health with equal rights, opportunities, respect, and autonomy. This is the vision then. The goal is to reduce the stigma, impact, and burden of neurological disorders, including associated mortality, morbidity, and disability, and to improve the quality of life of people with neurological disorders, their carers, and families. And the guiding principles of the plan are, as you can see in the slide, people-centered primary health care and universal health coverage, integrated approach to care across the life course, evidence-informed policy and practice, gender, equity, and human rights, empowerment and involvement of persons with neurological disorders and their carers, and intersectoral action. The plan proposes specific actions for member states, for the WHO Secretariat, and for international and national partners for each one of the strategic objectives that I will show to you in the next few slides. And in reaching the 10 global targets of the plan, countries can set their own national targets, taking into account national circumstances and challenges, of course. The first strategic objective is to raise the prioritization and strengthen governance. And it has 3 action areas: advocacy, policy plans and legislation, and financing. I'm not going through the details of each of the action areas as we have limited time, but I would like to stress that comprehensive action across all strategic objectives and action areas is needed to achieve the global targets. As you see how the plan sets out, you can see here how the plan set out the targets, and I will walk through for the first one, but similar structure is followed for all other strategic objectives that I will show you soon. So for the strategic objective 1, the targets are 2, that by the end of the planning period in 2031, 75% of countries will have adapted or updated existing national policies, strategies, plans, or frameworks to include neurological disorders, and that 100% of countries will have at least one functioning awareness campaign or advocacy program for neurological disorders. The second objective is about providing effective, timely, and responsive diagnosis, treatment, and care. And the action areas are care pathways, medicines, diagnostic and other health products, neurological workforce, and carer support. And you see all the details under each one of them, right? For this strategic objective, we have 2 targets. One is related to neurological disorders within universal health coverage benefits package. And the second one is on access to essential medicines and basic technologies for neurological disorders in primary health care. Moving now to the third strategic objective, you can see the integrative approach that WHO is taking for promotion and prevention. And the action areas are promoting healthy behavior across the life course, infectious diseases control, trauma, still in the same objective of reducing environmental risks and promotion of optimal brain development for children and adolescents. One of the targets here is about brain health promotion or prevention programs, while other is linking to other relevant targets, namely NCDs, non-communicable diseases, defeating meningitis, and newborn action plan. The fourth strategic objective is to foster research and innovation and strengthen information systems. And the action areas are investment in research and data and health information systems. And the targets here are pertinent to collection and reporting on a core set of indicators for neurological disorders and global output on neurological research. I understand that may be a bit too fast to keep all the information, but all this information is available. Maybe you have already, hopefully you have already seen, contributed to it, or you can access to it after the session. So I keep moving to come to the final objective, which is focused specifically on epilepsy and strengthening the public health approach to epilepsy. And the action areas are access to services for epilepsy, engagement and support for people with epilepsy, and epilepsy as an entry point for other neurological disorders. The targets to this objective are focused on service coverage for epilepsy and promotive and protective legislation for people with epilepsy. So to conclude, the way forward is about the need to integrate brain health and neurology into government plans and budgeting at all levels, prioritize activities for promotion of brain health and prevention, treatment, and care of neurological disorders, to engage stakeholders, including people with lived experience, and to consider the different audiences for your message and make the case for investments. And with this, before I turn you for comments and questions, I want to acknowledge the contribution from stakeholders across the world who participated in the consultation process and provided their inputs. And this includes people with lived experience. And I believe that for people with neurological conditions and neurological disorders and their families and carers, this is a lived reality and a chance for making a substantial difference. And I thank you. And just to say that with us today is my colleague Talon Dua, who many of you know, hopefully most of you, and she has been leading this exercise as the unit head of the brain health unit in the department. I will have to leave in a few minutes, but Talon is joining us in case there is a follow-up conversation. Thank you, and back to you.
Thank you for that presentation, Deborah. Now we will take any questions or comments from the panel. Question: how does it apply to ME?
Yes, Deborah did say that she has to leave in some time, so she may be leaving. I'm just checking if Deborah, you are online and you would like me to take this question.
I was just trying to leave. So if you take it over, I will appreciate. Thank you very much.
Thank you. No, I understand that you have been called for another meeting. So thank you, Deborah. Thank you very much. Yes. So no, thanks for asking this question. As you see in the title of the action plan, this is Intersectoral Global Action Plan for Epilepsy and Other Neurological Disorders. So while epilepsy is because has been with a specific strategic objective identified as one of the priority conditions and as an entry point. If you look at the other issues such as policy, governance, service, diagnosis, treatment and care, prevention and promotion, research and information systems, this applies to all neurological disorders. So the action plan is about strengthening services, strengthening systems for all neurological disorders going forward.
Question: what is the focus for WHO with regard to post-COVID conditions, some of which are strikingly similar to ME?
Yes. Can you hear me now?
Yes, we can.
Yes. Okay. So thanks very much again for this very important question about post-COVID condition. As you may be aware, this is an area of specific interest to WHO, and we have been having a series of webinars as well as reports looking into the issue of post-COVID condition, specifically related to recognition, research, and rehabilitation. And this is the important thing, I think, which would be very relevant, is the engagement with people with lived experience, as all the work is happening in this space. You would have also seen the definition of post-COVID condition that has been come out from WHO. So as you know, that when we think about different symptoms of post-COVID conditions, such as cognitive dysfunction or shortness of breath, we understand and we know that the fatigue is often debilitating, and that there are, if you look at issues like lack of data, research, knowledge into the pathomechanism, there is a need for better understanding. So for one, moving forward, the WHO is actively working on promoting research into the different aspects, including fatigue, and also that how can we have synergies explored and foster strategic approaches to research and innovation in the field of post-COVID. So, for example, how can we use novel technologies, precision medicine, and look at different treatment options, and as we said, linking with the other conditions. And last point that I would like to make is that most of this research is, as you know, is happening in high-income countries. How can we work together to have more data, more information around this from low and middle-income countries? So clearly, a lot needs to be done in the area of post-COVID.
At last year's EMEA, EFNA Roundtable webinar, Dr. Catherine Behrens, from the European Commission's DG Research and Innovation Directorate, presented an overview of what the European Commission was planning in the brain research area. Dr. Behrens discussed the support for brain research from the European Commission research budget and mentioned some projects that had been funded, although not always successfully. She confirmed that no funding would likely be specifically allocated to ME, CFS, something which was always expected. However, she mentioned the new opportunities, where funding may be allocated for research into a subset of under-researched medical conditions, and that there would be a scoping exercise for this. This could be something in which ME, CFS could be included. Dr. Behrens was invited to speak today, but, as there was no more news, then there was little more to present at this time, and so she gave EMEA an update, and it was agreed that we will remain in touch, and will revisit the status of this later. The scoping exercise has now been postponed until later in 2022. We expect eventually that there will be a call for tackling under-researched, high-burden medical conditions, and that this will include ME, CFS. Meanwhile, there are already opportunities for funding research into ME, CFS in Europe, and the European ME Research Group is exploring them. During 20 Harold Angelson and during 2021, EMEA Norway member, Norwegian ME Association, NMEF, and other members of EMEA, worked together to conduct the first pan-European survey of myalgic encephalomyelitis. The idea for a pan-European survey among ME patients originated when a patient survey carried out by NMEF, and later supplemented with a similar survey in Denmark, identified strong similarities in the time of onset of the illness among ME patients, with a peak in 2009, the year of the swine flu pandemic. Was there a similar pattern occurring in other countries? This then led to a discussion, and posed other questions on the similarities and differences across European countries. National ME patient surveys, conducted by the ME organizations within EMEA, have become an important source of information and knowledge regarding the situation of ME patients in a number of countries. Harald Angelsen and Trude Schei from NMEF designed the survey and worked with EMEA member groups together to conduct the survey over several months. Today, Harald will present the first results from the survey.
Thank you. Great, thanks for this opportunity to present a few results from, as the introduction was saying, the first from a survey that we did. These results are preliminary, although some of the patterns and basic statistics that you will hear about today are kind of out. I think there's a lot more needed in terms of interpreting and putting it into good context to explain some of the differences. So this is just a brief outline. Yeah, I don't go through the points as you will see them. I discussed with Trude and Nayana if I should have black background. I think I'll do that just as a reminder of the general picture, and black is the color that best describes some of the findings. So the survey and the respondents, I think one point that comes out that the strength of ME organization, kind of the degree of organization membership varies greatly, and that's reflected in the survey. Just a few words on the survey. It was a relatively small one, 18 questions. The average time was 8 minutes. We translated to a full 15 languages. As you can see on the long list here, all the major languages of Europe, at least of the western part of Europe, but also some on at least the old Eastern Bloc, like Croatian, Serbian, Czech, and Hungarian. The survey was open for about 3 months, from May to August. So this was kind of implemented by the Norwegian ME Association, and that may be reflected in the number of respondents that we got. So in total, 11,297 more or less complete answer, but what I mean is that some may have not answered one or more of the 18 questions, but we deleted a few hundred that was kind of incomplete to the extent that it was not worth including. From 10 countries, as you can see on the list, from Finland and above, we had more than 400 respondents, so we kind of have some more confidence when working with those countries and divide into subgroups. We also included a few mainly English-speaking non-European countries, the US, Canada, well, that's also French-speaking, of course, and Australia, New Zealand, as you can see on the list. And it makes also an interesting comparison, as we'll see. I should say that all this type of service, there are potentially biases in the sampling because it's voluntary. So, for example, there is likely to be an underrepresentation of the very ill. It may also be an underrepresentation of those that have recovered from ME. So we should keep that in mind, that it's not kind of scientifically drawn a sample from a population. That registry does not exist, at least not in Norway, and I guess in most countries, to have kind of a central registry of people with an ME diagnosis to draw from. So Severity of the illness. Couple of conclusions that are displayed here. Degrees of severity, both the international consensus criteria, that is also the Norwegian national CFS EMEA guidelines by the Health Directorate. They have this 4 categories of that, and also better than mild and completely recovered. In general, very severe, totally bedridden, and need help with basic functions. Severe, mostly bedridden. Moderate, mostly housebound, but mild. That may sound not that severe, but still you have at least a 50% reduction in pre-illness activity level, and may, for example, not be able to work, at least not full-time. So even mild is serious. And that's, I mean, the terminology is indeed a problem when using and discussing, for example, for social security benefits. The severity, and this is kind of the first major graph I'll show on this, is that the most dominant is this group here in the middle, the moderate, the sick, that is those that are generally housebound, of about 54% of the total sample. Moderately ill, severe and very severe, which you will see some reports. A figure that's often used is 25%. Here it's somewhat lower than that, but we are not sure whether it's because they are underrepresented in the sample, or whether the 25% that's commonly used is kind of a slight overestimation. I guess it also depends if you include those on the top, better than mild, if they have EMEA or not. So there are a few definitional questions also. If you look across the globe, and this is a few figures with the same distribution of severity, one country stand out, and our good Nordic neighbors of Finland, that it's a very much higher proportion of mild there. I mean, we could use some stereotypes of Finnish people of being kind of sturdy and enduring people that can stand a bit of pain and sauna, etc. Could be an explanation, but it's at least interesting to observe it without the survey giving good answer as to why it is like this. One of the things that have been in a few studies is the link between severity of the illness and the age of onset. So in this first figure here, we compare those that the onset was more than or 20 years or older, whereas those who got it as teenagers or even younger. So among the very severe group, you see that those with an early onset, you have a much higher share, 4.3% in the very severe group. And also in the severe group, 21 versus about 15% here. So those who got ill after the age of 20, or those before. So much higher proportion here among the severely ill. It's not kind of a prognosis telling what's the likelihood of you becoming severely ill if you get it early, because there are some, at least studies maybe, that if you get ill as a teenager or before, you may also have a higher likelihood of recovering than if you get it, say, at 40. This is just the same figure where the cutoff age is 16 years. So you can see that it's even more pronounced here. But a result that seems to be fairly robust and confirmed this positive link between severity and age at onset, and with some 11,000 respondents across a number of countries, it seems to be confirmed. As was mentioned here, one of the early motivations for this was when we observed the year of the onset, not of diagnosis, this is the other figure here, but the year of onset, and that we had a peak in Norway for 2019, which was the year of the swine flu some of us remember, and kind of an unusually high peak here. Do we find the same when we looked at all the respondents? And the answer is cha, which is a soft ja in Norwegian. Because if you look at 2009 here, here's for all countries, the pattern is not as clear. I should make one major caveat to this, and that is I'm a professor of economics, and I've done a few surveys also with recalled questions, and typically you get a peak for 2000, 1990, 2010. So if we adjust for this, that it's probably people seem to remember better the round years that ending with a 0 than other years. You have, there may also be that, but perhaps not as pronounced, or not as pronounced as we saw for Norway. Of course, the decline here that we see the year of onset does not mean that fewer people get ME. If you look at the year of diagnosis, and it's steadily increasing, and as we'll see shortly, it's a long gap between the onset and the diagnosis. Triggers we looked at, and we need to do some more analysis because we had an answer of other that is quite significant. But infections, if you look at the total here, infections are about half of the respondents reported that it was an infectious disease that initiated, that triggered ME. Followed by, well, the large category of other, and some of that may even be infections. And then no particular event, they can locate it. A few others, traumatic life event, vaccines, accidents, injuries, as you can see. I mean, one pattern, this gives it across the different degrees of severity, that it's relatively less severe if a traumatic life event was the trigger of the illness. Diagnosis period. Here's the pattern that you find just in histogram, which is the years between the reported onset and the year of the diagnosis. So in the same year, so we look here, 7% of the respondents have received the diagnosis in the same calendar year as they got sick. It's very fast for some, but you see the typical pattern 1 or 2. If you look at the mean or the average, it's close to 7 years. The median, or 50th percentile, the median is, I mean, the year. So after 4 years, half of the patients have been diagnosed. If you ask P75, so how many years does it take for 75% to be diagnosed? And the answer is 9 years. So you have a very long tail here on this right-hand side. I should also add that when we ask about diagnosis in some countries, for example, Serbia, that we had a few respondents from, it's not actually given, so it is something that may be similar and used as the diagnosis for ME, and not the ICC official diagnosis. Here is the variation across countries, and the median from 2 years in non-European countries, Australia, Canada, UK and Ireland, up to 7 years in Iceland, but also other Nordic countries and Croatia having a median of a full 6 years. So substantial variation here, I would say, more than kind of was to be expected. By gender and severity, so in general, women, it takes almost a year longer to be diagnosed. The median 7 versus slightly more than 6 for men. And we looked at the pattern particularly. You can see here, here's female in the orange and male are blue, and the difference for different levels of severity. There's not a clear pattern in kind of the diagnosis period when you compare severity, except for the recovered. But remember, there are very few respondents in this group, so maybe not put too much emphasis. on this, but I think it's interesting to see that how dramatically different it is for this small group that have recovered. Is the diagnosis period getting shorter? And we could look at that and look at what is the year of the diagnosis and how long have you been sick before you were diagnosed. And this is for all countries. It's not going down, fairly stable over the last decade. Again, a lot of country variation and well, you have a small course here in reading Norwegian, but the diagnosis period for Norway has actually slightly been going down, but for neighbors, Sweden, Denmark, Finland, maybe not, and UK and the Netherlands, just to take two examples, been kind of increasing here. The gray area being the confidential interval for those that are into statistics. Course of illness and factors affecting it. How are patients, what are this kind of self-reported courses of illness? And this was one of the main motivations for the Norwegian study, because there is a lot of debate about, are they getting better or getting worse? Here are the two main results. And here are some of the more precise figures. We had 7 different options. They could say general deterioration, initial fluctuation, and then entering a more stable path of either stabilization or gradual deterioration or gradual improvement. So those two red here are those that are in deterioration, some after an initial period of high fluctuation. So that's close to half. About a quarter, the gray area here, reporting fairly stable, and then, fluctuating, the gray, and the blue areas being a more stable area. And then the two green at the bottom here are improvements, so less than 10%. We also asked about the current trend, but I'll leave it for now for the sake of time. Again, country variation here. Norway doing relatively better compared to, for example, Sweden and Denmark here. Oops, sorry. UK and a few other countries. Germany is a country that kind of, I should not say whether surprised or not, but that for a number of things comes out either rather even more black than for other countries, to put it that way. And you can have a look here at the, for the various countries. Good samples from both France and Spain, a few less from Italy. So, but you see a similar pattern here with some country variation, and very few kind of reporting improvements for all countries. The share in deterioration that, as I said, close to half getting worse, but at the same time finding substantial variation across them, from Ireland and Norway at the bottom up to Spain and Sweden on top here. And it's interesting to see two countries that are neighbors, Norway and Sweden, and in many ways are kind of praised for good welfare systems and the welfare state globally, but quite a marked difference. Negative and positive factors was a key thing. What contributes to a positive change in the course of the illness, and what negatively? So I grouped here the factors that are negative, and you can read it here. These are, if I had more time, I would have made it a bit nicer, but it's just the name of the variables in my startup program. Stress and worries, activities causing post-exertional malaise. PEM is the dark red here, or brown. The green one being CBT, cognitive behavioral therapy, as a cure, financial and family caring also. Family obligations being a burden and one negative factor for the course of the illness and for the symptom burden. On the positive, as I mentioned, activity regulation is key, and these two factors here reflect that. Pacing, using the energy envelope to regulate the daily activities, The green one, acceptance of the disease, symptoms, treatment, some overall slightly on the positive side of the scale, reporting positive on the alternative therapies and also cognitive behavioral therapy as coping. Coming back to that point in 1 second. So the pattern is very much similar to we found in the original Norwegian study, and it doesn't seem to vary a lot across the country, so I'm not giving any country details on this. So NICE guidelines was out, and one of the key changes there is the distinction between cognitive therapy as a way of illness management, as a way of coping, and versus as a potential cure. And we were wise, and Trude was wise, and we included, we made that distinction in the survey to see how the different experiences are and how also, for example, how that is affected by the severeness of the illness. So the initial analysis I did was just for Norway, so I just present that as to just see the huge gap between here. CBT as a cure, and very negative in red here, and neutral and positive in shades of green at the bottom here. So CBT as a cure, well, it's rare to find so clear differences and such a clear kind of visual display of the difference between the two. So the ratio of kind of negative to positive experience as a cure is 1 to 28. So for each one reporting that it has a positive effect, there are 28 reporting that it has a negative effect on the course of the illness and the symptoms. CBT as coping, on the other hand, we found a ratio of 3 to 1. So for everyone with a negative experience, there are 3 having a more positive experience. So it just means that it's crucial to make that distinction. Now, do we find the same pattern in other countries? And the answer is yes, indeed, we do. Here's the total, and the numbers are not too different from Norway. As you see, Norway is up here, the top northwest corner here. There's one country that stands out in terms of negative experience, and that's the home country of PACE study and lightning process and other kind of cognitive treatments. And 85% of the respondents reporting negative or very negative, in fact, a lot with very negative experience. So it's kind of overwhelmingly 1.5 some positive, and in fact, no one with a very positive response here from the UK. And you can see the pattern around others, also the Netherlands, quite negative, Denmark, others, but the pattern is across the countries. The coping question that we found for the total, you see here, I said the ratio for Norway was 3 to 1. It's slightly less here, some 24-25% with negative experience and 35-40% with positive. What is interesting, in general, they're more positive than negative experience with CBT as a coping strategy, coping and management strategy. But a couple of countries stand out. UK, still a lot more with negative, and this even more so in the Netherlands. So is it that just CBT as a coping mechanism or coping strategy or coping help, it's too exhausting and kind of initiating PEM, or is it that it's associated with CBT as a cure, that also this type of treatment, to the extent it exists, is not yielding the positive results as it potentially could do. The The CBT experience is a lot worse for those that are severely ill. Here, just rank them from the darker red is the more severe is the illness. And again, this score with -2 being very negative and 2 being positive and 1 neutral. So for the very severe, you have a score of -5. So it's the average is between very negative and negative. So, and it's interesting that it's also the same pattern here for CBT as a coping strategy. The final element that I'm talking about, let me see how I'm doing on time. Okay, support from public services. A dark picture with some shades of black across the countries. The healthcare system, we also had a similar 4 or 5 kind of Likert scale where we have no or little support, or medium, or good and very good support. So those who said we get no or very little support from the healthcare services, you can see the ratios here. 3 out of 4 patients say they get no or little support. There is some variation. Austria didn't have a lot of respondents, but some. Italy here. But you see also countries that you think maybe would perform better are quite negative. I want to make this Norway-Denmark comparison because it's another country that have quite a few similarities. In Norway, 17% say they have good or very good support, 16% no support. If you go to Denmark, this is dropped to 4%, the positive, and the negative goes from 16 up to more than half, 53. I looked at some scores for kind of the health, kind of assessment of the health system in countries, and in some surveys, Denmark is on top in Europe. So, but in this survey is close to the bottom. So why? And I think I follow some of the debates in Denmark where you have a very strong psychosomatic view on EMEA among key actors, among a few clinics, and you have a different kind of health and social security system as well that's more privatized, and this psychosomatic thinking has been also penetrating that in the way that some of these actors are working for the companies and say that well, EMEA is partly a self-inflicted diagnosis, and you can get okay with, for example, cognitive therapies, and therefore that's a basis for refusing to give support, both in the healthcare system and social service system. I made a small index of 3 indicators that we ask, or 3 things we ask about, namely the healthcare, social security, and social services, just weighted them, 50% to healthcare and 25% to these, and just made a score. I use 0 to 4 here, with 4 being very good support and 0 non-support. So here just the countries listed alphabetically, with the red being at the bottom, average score of 0.5. So again, between no support and very little support. Croatia, Italy, Serbia being at the bottom. 2 old Viking countries, Norway and Iceland, on the top here. But one interesting is that Australia, Canada, and the US, so those in blue here, are doing quite okay compared to most European countries. So Europe should maybe not brag too much, at least when comparing to these countries. I looked at some of the factors that influence, and for example, there is a strong negative correlation between the diagnostic period and the satisfaction. Strong negative one. So the longer the diagnostics period can be or is an indicator of how well the kind of public support system works. A few conclusions. I think just overall, when we're treating, not distinguishing the countries, I think we found a few interesting things. Some are not new, but it's nice to have them confirmed in such a large survey. Infection triggered about half of the onsets, maybe slightly lower than you find in some other literature. Early onset and the severity of the illness is positively linked as finding. Mean diagnostic period is 7 years, the median is 4. If you look at the course of the illness, almost half is getting worse, and less than 10% are improving. I just talked about the CBT as a cure and the critical of making this distinction in cure and as coping mechanism, and the overwhelmingly negative experience that we get here. And 3/4 say that they get no or little support from the healthcare services. When we compare across the countries, I think the similarities for the illness patterns are there. There's not a lot of variation in the distribution and degrees of severity, with the exception of Finland. Young at onset and severity, factors affecting the course of the illness, pacing and activity regulation, support from family and fellow patients I didn't mention, but that's strong and it's across the continent. Where you find the big variation is in the healthcare, diagnostic period, public support more generally. And that has implication, for example, in the course of illness, where there is some variation across countries, and though we have to do some more analysis to see that, I mean, the good hypothesis just by looking at the data is it has implications. And maybe also, as I mentioned, it's somehow harder to explain the CBT as a coping experience that for some countries also that is quite negative. So that was a glimpse into this. We plan to make of course, a more thorough report to be published eventually sometime later this year, and also make some proper research article out of this. But here is a first glance of the survey. Thank you.
What is your comments on the use of different diagnostic criteria in different countries?
That's one of the things that we have discussed with Richard, is to try to get more and see the diagnostics criteria used and how that is both for the diagnostics period, maybe for the distribution on the severity, and how that. But at least I don't have, and it would be good if some have that overview. I think, for example, we see that the diagnostics period is quite short in Ireland and the UK, which may be an indicator they have used somewhat more relaxed criteria, shorter period, that you need to have experience fatigue before you can get the diagnosis. So it's a good hypothesis that the diagnostics criteria is partly determining the differences we observe in the diagnostic period.
But actually, we have no data on how they are used, so we cannot be true about that. Thank you.
How many people are suffering from ME, CFS in Europe? What is it costing economies? How are cases recorded? How do we know the problem if it is not even being measured? How do we know what progress is being made if we have no accurate and reliable data to compare? How do we overcome the challenges of ignorance, misinformation, flawed policy making? If we have no answers, then we stagnate in the same status year after year. If you choose not to deal with an issue, then you give up your right of control over the issue, and it will select the path of least resistance. SNOMED stands for Systemized Nomenclature of Medicine. SNOMED clinical terms, or SNOMED CT, is a structured clinical vocabulary for use in an electronic health record. It is a systematically organized computer-processable collection of medical terms providing codes, terms, synonyms and definitions used in clinical documentation and reporting, and it is the most comprehensive and precise multilingual, clinical health terminology product in the world. The primary purpose of SNOMED CT is to encode the meanings that are used in health information and to support the effective clinical recording of data with the aim of improving patient care. SNOMED CT's comprehensive coverage includes clinical findings, symptoms, diagnoses, procedures, body structures, organisms and other etiologies, substances, pharmaceuticals, devices and specimens. SNOMED CT is maintained and distributed by SNOMED International, an international non-profit standards development organization. Today, Ian Green from SNOMED will present an overview of standardization, consistency and collation of data, something that would be very useful for supporting advocacy and policy making with ME, CFS.
Okay, so thank you for inviting me to this webinar. I'm unused to kind of like an automated introduction, but we'll kind of work with it, I guess. So my name's Ian Green. I work for SNOMED International in a variety of roles. I'm customer relations lead for Europe, but I also head up global clinical engagement, both of which are probably applicable to this afternoon's talk. So a bit about the agenda, I guess. I'll talk through a bit about SNOMED International and give you a bit of background to the organization itself. Then talk in general about SNOMED CT and how it's applicable to this particular, well, to ME in particular, and chronic conditions more generally. They'll take you through a bit about interoperability and standards and where we fit in particular around collaborations. And then really not necessarily strictly restricted to SNOMED, but I'll talk a bit about standardization, a bit about making sense of data, and a bit about how analytics can help. So first of all, I better tell you about SNOMED International. So as the introduction said, SNOMED International, we're an international standards organization. SNOMED CT itself is a licensed product, but the organization itself is owned and governed by 43 member countries. So essentially, countries join SNOMED International. When they do so, it means that the use of SNOMED CT in that country is covered by a national license, and therefore, to all intents and purposes, for end users, it's free, as any license fee is paid nationally. You can see from the map here, the darker colors are member countries. In terms of Europe, well, in terms of Europe itself, there are 22 countries in and around Europe that are signed up as SNOMED members. And if you expand that out to affiliate licensees, which are individual organizations within countries, which tend to be large academic hospitals, you can see we basically cover almost all of Europe. And particularly at the moment, there is a push from the European Commission itself to try and standardize SNOMED usage across the European Union. So there are a number of European countries at the moment that we're in discussions with regarding membership. Just in terms of the organization itself, we're headquartered in London, which is a bit of a strange statement. What that actually means is we have a post box and a phone line in London. To all intents and purposes, we are a completely virtual organization and global workforce. So I work with colleagues in North America, in Europe, some in the Middle East, and certainly some in Asia Pacific and Australia in particular. The membership dues, so when countries become a membership, it's based on national wealth. So essentially, the more profitable the country, the more you pay. The flip side is also true. So for particularly countries in Africa and other countries globally where they have low income, we actually have a policy to support low income countries. So essentially we allow SNOMED use in those countries for free. So I guess I better tell you a little about SNOMED CT. First of all, the introduction wasn't quite true. So SNOMED itself has been in development for about 40 years, close on. Originally, as the introduction said, it was called the Systemized Nomenclature of Medicine. We have kind of put that in the past, so that's a little historic. So now we just call it SNOMED CT. We don't bother trying to expand it out. The most important part about it, as the introduction said, it's a global clinical terminology, but the more important bit is the fact it's built on ontological principles. So it's more than just a code system. And I'll touch on that in the forthcoming slides. So a bit about, I guess, about the terminology itself. So it is the biggest terminology globally. In terms of concepts, so if you think about the individual items, if you like, within SNOMED CT, we have just short of 500,000 items or individual concepts. It's important because each concept has its own unique ID. And the driver for SNOMED CT is really about computability. It isn't just about the words appearing in a computer system. It's about those words having a computable meaning which sits behind it. That's important both in terms of how you transmit that information between systems, and it also feeds into analysis, which I'll touch on in a while. With each of those concepts, so much though I might like numbers, most people would find those numbers completely useless. So I wouldn't expect any of you to know what 254,83709 is. So associated with each concept, we also allocate some descriptions, so human readable terms, if you like. The descriptions themselves, we have about 1.5 million descriptions, and each of the concepts are structured in a similar manner to this dark blue box here. So we have what we refer to as a fully specified name, which is the one at the top, which essentially has a human readable term, and then you'll notice there's a bracketed component at the end. The bracketed component or semantic tag simply tells you what type of concept you're looking at. So if you're talking about malignant neoplasm of breast, you're talking about a disorder. But when it comes to clinical language, there are lots of complexities which apply to clinical language. So associated with each fully specified name, we also allow a number of synonyms. So things like CA for breast cancer, malignant tumor of breast, so tumor rather than neoplasm, etc. We also use the synonyms to allocate translations. So if you were looking at these, I'll take a lead from our previous speaker. If you're talking about these in Norwegian, then you see the Norwegian text here rather than the English text. Also within each release of SNOMED, so a number of synonyms is very helpful, but if you're looking at a screen in front of you, you expect to see a single term. So with each release, depending on which country it's in, there is also a preferred term that's allocated. The bit about the ontology comes over on the other side here. So where we talk about relationships, so inferred I'll tell you about in a second, but in terms of relationships, there are just over 3 million relationships. Within SNOMED itself, everything has what we refer to as an ISA. So if you think about that in terms of a hierarchy of terms, a term within SNOMED must be associated with a parent term. It must be linked to something else. Then we also publish a concept model. So for each type of concept, there are a series of attributes and values which can be allocated. So in the case of neoplasm, well, in the case of disorders in general, we can allocate finding site, we can allocate associated morphology. So finding site being breast structure, associated morphology, malignant neoplasm, etc., etc. That's important because when we create or when we author SNOMED, We then run it through a computer classification process, which is where the inferred component comes in. So the computer literally allocates links between concepts, which as an author, we don't do. And even if you wanted to, you couldn't do, simply because of the size of SNOMED itself. You couldn't be expected to know all the links between 500,000 concepts. As we would say in the UK, we're good, but we're not that good. In terms of chronic conditions, so first of all, brief following on from the introduction, the structure of SNOMED, so yeah, the top level concept, if you like, is a SNOMED CT concept, and everything else is associated through ISAs, as I said on the previous slide. To give you some ideas of the type of hierarchies, as you know, as has been said previously, we have things like clinical findings, we have procedures, we have body structures, we have observables. So we have a number of different things. All of these are associated with each other in SNOMED, which is important. If we take the example of ME, as that's what the focus of this afternoon is, ME we have as a concept in SNOMED, we have it as chronic fatigue syndrome. It's associated, so its parent, if you like, through the ISA is fatigue. And then it's modeled with links to the chronic nervous system disorder, and then with finding sites, interprets, and clinical cause. And you'll see here exactly the same as the previous slide. So chronic fatigue syndrome, we have ME. ME we expand out. Unfortunately, the use of acronyms in clinical practice is, as they would say, beware there be dragons. We need to expand them out. Acronyms don't tend to be unique across clinical care, unfortunately. So we have the expanded myalgic encephalomyelitis, and then also myalgic encephalomyelitis syndrome. They're all the same thing, but equally we include things like Iceland disease. In terms of, I suppose the other topical issue at the moment is long COVID. Long COVID is in SNOMED, but it's in SNOMED as post-acute COVID-19 disorder. And it's a disorder following viral disease, and it's modeled with an attribute of after, so acute disease caused by severe acute respiratory syndrome coronavirus 2. Exactly the same here. We have long COVID. There's also long haul COVID. We also have a text definition, so symptoms attributed to SARS-CoV infection that persists for more than 4 weeks following onset with a negative infectious virus status. So just in terms of the things that you're looking at here, if you go into our international browser, which is the link I've put on the bottom here, you'll find there's a search function. No one has yet managed to break it. So if you put any series of terms, any words in there, you'll find it returns individual concepts. If you click on the concepts, we have a diagramming standard, which is what this is with all the different colored boxes. They're available for every concept in SNOMED, so please go and have a look. In terms of interoperability, so having a global terminology is fine, but it only works if it talks to other systems. So SNOMED itself is really about the terminology which appears in a system. So if you imagine you're in a hospital, you're in a clinic, you have a computer system in front of you, that's where SNOMED appears. But to transmit it from one system to another, you need interoperability standards. So we work with HL7, both in terms of the newer kind of HL7, which is FHIR, but also in terms of the older versions, so version 2 and CDA, clinical document architecture. We provide implementation guidance for both. So it's not about just the fact we work together, but we also tell people how that arrangement works, if you like. In terms of the content itself, we are a member of ISO, and through ISO also we are putting together a formal relationship with CEN in Europe. So we have links to TC215, which is the health informatics group within ISO. We also have a large number of collaborative agreements in place with other standards bodies, and I'll cover those in a couple of slides' time. The fact we're a concept-based terminology is important, really, particularly when it comes to analysis. So having lots of different words in use is fine, but when you come to analyze it, that can be challenging. And that's the reason we use synonyms. We also make sure that we don't just choose any synonyms, so they're all true synonyms, and we have them clinically verified, if you like, before we add them. It's there to support clinical use. We also support translations because of cross-border care. I'm based in the UK, but I'm not so naive that I believe everybody speaks English, unfortunately. We also publish mapping files between standards, and we align those to the latest release. So for example, one of the files that we published with the international release is a mapping between SNOMED and ICD-10. We also have, there are also a number of projects either that use or are in the planning stage to use SNOMED CT as a semantic layer. What I mean by that is if you think about across Europe and all the hospitals in Europe, even within member countries, some will use SNOMED, some will use other systems, so either other terminologies or other classifications. When it comes to analyze them, what a lot of projects do is tend to map everything to SNOMED and then do the analysis on SNOMED, just for the ease of analysis more than anything else. And that's what it means when we talk about semantic layer. The biggest one by far that uses it is something called Odyssey, which is the global research network. They essentially use SNOMED as the semantic layer. You can run queries against hospital data anywhere in the world and share those results because everybody is using the same system. When it comes to looking, they're all using SNOMED. In terms of collaborations, like I said, we have a lot of them. I'm not going to read through the whole slide. There's a number of things which are which I would think would be key to these discussions. One is the fact we're just reviewing it and updating it, but we have collaborations with WHO. The Joint Initiative Council is something you probably haven't heard of, but the Joint Initiative Council is a group which brings together all standards organisations together, ourselves included. Things like DICOM, which is linked to imaging standards, and then GS1, which GS1 are the barcodes that appear on drug labels. But there are a number of others. Some are clinical, some are more standards based. We also have a number which are pending finalization. The key one probably with this discussion is we work with Helen Cross at ILAE. So at the moment we have a project basically bringing in the ILE classification into SNOMED and updating the diagnosis of epilepsy throughout SNOMED. Well, epilepsy and seizures actually, not just epilepsy. So standardization of clinical recording. As I said at the start, there are, so if you think of Europe, there are 22 countries that are members of SNOMED International. Although there are national agreements in place to use SNOMED CT, if you look at the individual countries, their implementation is very different. So within the examples here I've used in the UK, the US and Germany, the use of SNOMED is actually nationally mandated, either in terms of national agreements, or in the case of a number of these, actually in legislation. So they're actually, it's a legal responsibility for people to use SNOMED. Within other countries, there's less mandation, but it's the push to use SNOMED is through e-health strategies, and they are different between countries, but they set out the approach that's to be taken. There's also standardization through national directives regarding system procurement. So with a lot of countries, if you're an organization looking to buy a system, there'll be some standardization around the procurement. So if you want money, you can't have money unless it uses SNOMED. In some countries, particularly smaller countries, you'll get standardization simply because there's a single vendor. So if there's a single vendor across the country, there is no surprise that the single vendor will use the same system. The key driver, though, to all of this is to get the delivery of a structured clinical record, and where possible to limit the amount of free text options. That doesn't mean that clinicians can't write free text, but it does mean that where possible you try to structure the clinical record and get a coded answer to the questions, if you like. Although with new developments you have things like natural language processing. Natural language processing is very useful, but it's also fairly time consuming. So if you're looking at transforming free text into codes, you can't normally do that in real time. There are a number of issues. So one example here, particularly from the UK, simply because I was talking to them literally 3 days ago. Within a national level, there's quite often minimum data sets that are specified at a national level where they're enforced, essentially enforced data collection around specific clinical areas. So in the UK, we have one for the emergency care data set. So if you go into any casualty, any accident emergency department, they will all collect the same data on all the patients. And then you can make some assessments, some analysis at a national level on an ongoing basis about the throughputs, looking at trends, etc. With a lot of these, we look at leveraging existing data flows where and if possible. So within any country, you'll have a number of data flows. Not all of the data will be useful, but some may be. And by taking some of that data from different data flows, it helps you to build up a picture of a specific clinical area. With all this, so if you're dealing with clinicians, one of the biggest kind of drivers is that if you're doing data collection, you need to provide regular feedback. It's no good expecting clinicians just to record data and get nothing back. As with everyone else in healthcare globally, I think they're all fairly busy. And if you're looking to improve the data, well, there are issues with the data. The best way of encouraging clinicians to change their practice, if you like, is to give them feedback. That's nothing to do with SNOMED, that's merely to do with human nature. So if you've got all this data, how do you make sense of it? Well, as I said on the previous slide, the essential thing is to have structured coded data. If you're looking at some kind of reporting mechanism, the central reports to either national or international bodies, you need a pipeline. So it's not just about collecting the data locally, but it's how you get that data from a local location to a central point for analysis. And you need to think through what that pipeline looks like. In the good old days, a lot of that was done by standalone reports. So you get people to fill in reports, to fill in audits, and you submit the audit reports. The audit reports are fine, but they're always slightly out of date for obvious reasons, I would have thought. Looking at a more automated solution to this gives you more of a real-time sense of what the data looks like. As I've said previously, you need to identify the data flow. The data flow is key to this. So look at where it's from and also where it's going to. It isn't, if you think about ME as a diagnosis, it isn't just about looking at the diagnosis in a hospital setting. It'll be the hospital setting, it'll be primary care. You may even get referrals from social care. So exactly where is your data coming from? Having a specified data set is obviously very handy. So if you're looking at specific items, what are those items? Unless you specify them ahead of time, you won't be able to collect them. You then need some detailed implementation guidance for users, so the people who are actually collecting the data. So what are you expecting them to do? Are you expecting them to just complete their normal daily work, so use the electronic health record as normal, and you're taking data from it? Are you looking at additional fields within the electronic health record, and if so, when are those applicable? When does a clinician fill them in, essentially? Ultimately, it should be part of normal clinical care. Certainly, the move, the move in healthcare in general now is to put data first. Data drives clinical care. Doing it through an external process, doing it through audit is fine. It's not, we're not trying to get rid of audit, essentially. An audit has its place, but a lot of the monitoring of healthcare really does need a real-time view of the data to enable you to make changes and react and make improvements to action at the time. The processes, like I said, can support input from multiple terminologies. So even though I'm from SNOMED, I don't assume that everyone uses SNOMED in the world. And in fact, I know that statement is true. So the fact we have put so much emphasis on mapping is important, really, because it supports that central function. If you've got data, how do you make sense of it? How do you put it into a single format? How do you make it meaningful? What type of data types can you collect? Well, if you think about ME as a diagnosis, what do you need to know? Well, you need to know the person with the diagnosis. Kind of helps, I guess. So, but the diagnosis may occur in a number of places. So it may be in the current or past medical history. It may be in the problem list, depending on how the system's set up. Well, the big, I suppose the big focus is around clinical findings. So thinking about things like signs and symptoms, and particularly patient-recorded outcome measurements. So how do you feed those back into the system? Procedures, so tests and observations linked to it, so test results and general observations all have their place. So with most diagnoses, yes, there is a medical component, if you like, to it, but associated with that goes back to the clinical findings up here and really getting feedback from the patient themselves. The one thing I didn't mention about SNOMED, I guess, so I've focused a lot on using SNOMED in clinics, in hospitals, but SNOMED is also becoming more regularly used now in health applications. So things that appear on your phone, where you can report your symptoms, report your feedback. Those can then get added into electronic health records. We also cover things like medication, which may or may not be important, and then demographic data itself. So age, ethnicity, a lot of that demographic data, which is collected systematically throughout any health system, but also picking up, more importantly now, things around social circumstances. The WHO themselves have put a big push on social determinants of health, and we have a project looking at increasing the social care content within SNOMED CT. So assuming you have all this data, then what do you do with it? Well, hopefully, if you've done all the things previously, the end result should be you have a high quality data set. So you've got a high quality set of data which you want to do something with. What you then need to look at then is the axes of analysis. So what are you looking at? It's not just about counting the amount of occurrences. So if you're looking at ME as a diagnosis, you don't just want to know how many times ME has been diagnosed to a patient within a country. That will tell you something, but it won't tell you the whole picture. So defining what type of things you're looking at, the axes of analysis, is important. What SNOMED allows you to do, as well as using those individual concepts, so the amount of times those concepts occur, we also have something called an expression constraint language, which what it basically means is, if you think back to that slide when I gave you an overview of SNOMED CT itself, all those individual attributes, we can search on the attributes rather than the concepts. Now, the reason that's important is if you think about things like if you think of a term like Iceland disease, so Iceland disease may be associated with ME, depending on how you search for it. So if you're just searching for ME in a clinical record, you wouldn't return any instance of Iceland disease, because Iceland disease doesn't have ME. In SNOMED it does. But it allows you to pick up things like that, and there are a lot of those throughout clinical diagnosis in particular, where the wording between what would be the normal, if you like, clinical term and the surname is very different. So if you run, I mean, I've just ran an example here, but if you look for disease in SNOMED and you look for a clinical course of chronic, and you look at something associated with the nervous system, there are 323 concepts as diagnosis currently in the international release. It helps if you start to understand how this works in SNOMED. It gives you a better understanding of the axes that are available. So it gives you more ways of looking at the data, essentially. There's a whole kind of document around using SNOMED for analytics, of which I've put the link down here. If you're interested, certainly go and have a look through. It gives you some examples, but also some use cases from across the world of how that's done. And I'll stop there. So I'll just thank you for your attention. My email's on the bottom here, so if you have any specific questions, please email me. But also look at our website, there's a help desk function. We also have a number of clinical groups. We don't have one currently on neurology, but there's no reason why in the future we couldn't. But have a look at the directory under here. So I'm quite happy to take questions. Thank you.
Yes, thank you very much, Mr. Green. And there is already a question for you, and it's concerning the ME situation. And we saw that ME was in some way under the umbrella of tiredness, or general tiredness. And we know today that the tiredness, well, it's a very diffuse concept, and the major problems of ME patients are not always tiredness, it's much more other problems. So a question is, can this be changed in some way, or what does it mean, this hierarchy as you show? Yeah.
Okay, so in terms of, so let's take it up a level. So in terms of any concept within SNOMED, any concept within SNOMED can be changed. So it can be changed and updated. And that has to be the case across clinical practice generally. It's always been the case that clinical understanding of diseases changes and improves over time. With the advent of genomics and looking at some of the genetic variants, that's just accelerated. So first of all, anything can be changed. Within SNOMED, once a concept has been used, we obviously need to keep that concept within SNOMED and its definitions forever, essentially, to support longitudinal analysis. So if you were looking at a record that recorded ME in 20 years' time, you'd want to know what definitions we use today. So we keep everything which has ever been in SNOMED is still in SNOMED. However, we mark things for current use and then things for historical purposes. In terms of what you're talking about here, so if the definition, well, if the definition of ME has changed, we would look to you as specialists to work with us to tell us how that definition has changed, and then we'll reflect the change in definition within SNOMED. What we can't do with 500,000 concepts, which I would think is fairly obvious, we can't go through SNOMED and identify all those issues one by one. Firstly, we have a fairly small authoring team, but also you're looking at very specific expertise. So you as experts of ME, then please contact us. We would love to update the definitions in SNOMED, and that's a normal process, yes.
Thank you very much for the answer. That it is possible to be changed, and we will keep in some way keep in contact,
yes,
to discuss the update of a definition. But you mentioned also, which I think is very interesting, that you keep elder definitions to be able to follow longitudinally, which
Yes.
might be a good idea because of, well, everything changed, but we must also keep the long-term perspective in these disorders. So it's a good idea. Yeah, thank you very much for the answer. And I think we have another question that was also in this way. But time is running on, so I think I would like to thank you very much, Ian Green, and I see that SNOMED is developing. I have been in contact with it before in other disorders, but it's very nice to see that it's implemented in more countries. You have possibilities to translate between different classification systems, which I think also is very important. So thank you very much for your interesting presentation. Then we can go on to next presentation.
Professor Ola Didrik Sorgstad is a member of the European ME research group, eMERGE. He is a Norwegian pediatrician, neonatologist and neuroscientist noted for his research on resuscitation of newborn children and his contribution to reduce child mortality. He is a research professor at Oslo University Hospital and professor of neonatology at Northwestern University's Feinberg School of Medicine in Chicago. He is Professor Emeritus of Pediatrics at the University of Oslo and was Director of the Department of Pediatric Research at Oslo University Hospital from 1991 to 2017. He received the 2012 Nordic Medical Prize, is a member of the Norwegian Academy of Science and Letters and became a Knight First Class of the Order of St. Olav in 2010. In Oslo, a new model for a clinic for severely affected people with ME, CFS has been set up. For many years Professor Sorgstad has been supporting people with ME, CFS, and he will be presenting today news of this model clinic in Oslo.
Thank you. So I will present for you a new clinic for people with severe ME. We have just opened up in Norway. It's called Reisumtune. Next slide, please. So we had a dream. And I think you had to click because I have a lot of animations. We had a dream that we know that very and severely ill persons with ME are often treated by their family, parent, children, and not by the healthcare system. And those who are in institutions are often treated poorly due to no or little understanding of ME or unproven ideas that ME is caused by so-called deconditioning. And we know that there are many conflicts between ME people and caregivers. So the dream was, could we build our own institution in which care is based on present knowledge? Next slide, please. Where the patient in the center, where we respect the ME person's needs. So the process, you can just click down the whole slide, I think. So no, that was a little bit back, please. Yeah, I have a lot of animations. So I think you're going the wrong way now. Back. There, okay. Oh, there, yeah. So 4 years ago, the Secretary General of the Norwegian ME Association and myself, we started to travel around to existing institutions nearby Oslo. And then we visited Reisumtune, which is 70 kilometers north of Oslo in a rural, very quiet district. This is an idealistic church-based institution for chronic and difficult epilepsy patients. Now, the infrastructure was already in place there. There was an administration, there were nurses, a doctor or doctors, laboratory, psychologists, social workers, etc. And they had 12 single rooms in 3 separate houses vacant. Next slide, please. Next slide, please. So here is Oslo, and just click on. Yeah, and here is, oops, there, and here is Reisumtune. It's 74 kilometers north of Oslo. For those who know the area, it's close to the main airport, and it's a 65 minutes drive from Oslo. Next, please. So we started to discuss whether it was possible to establish this possibility for very severe ill ME patients. So we had a small group with 3 people from the EMEA Association and 3 from the institution. And in December 2020, an agreement was signed between the institution and the EMEA Association. And here you can see from this ceremony, this is me, and here's the president of the Norwegian EMEA Association. Now, in this place, the ME should be considered as a biomedical disease and treatment according to these principles. Costs should be covered by the public health system. And this requires an agreement for each case by the local county. In 2021, just 10 months ago, the first ME person moved in. And by April 2022, we have treated 11 patients. Of these, already 2 have recovered and actually have been went home, and a 3rd patient went home because of lack of public funding. So a few patients had to fund this stay by private fundings, which of course is not very satisfactory. So this is what it looks like. It's a beautiful place, and here's the winter time, the main building, and here is the laboratory, and here are the 3 houses, 3 similar houses like this, with 4 room and 12 single rooms, so we can have totally 12 patients. Next, please. Next slide, please. So this is what it looks like. Very quiet. All the rooms are isolated for light and sound. Staff, we have a daily head. He's a registered nurse. He has 15 years experience working in a big intensive care unit, and we have now 5 nurses, and we are recruiting 2 more. We have 2 health care workers. We have a doctor who is there once a week. He has long experience with ME, and I also have a small position, 1 day a month, to take care of research and development. Next slide, please. Yeah, so this is what it looks like, and see, it's a beautiful place. And next, yes. So what are we doing? We are applying a biomedical approach. We are using the new NICE guidelines for ME/CSF 2021 version as the basis for how we are treating these patients. We are respecting the ME person, and we are trying to establish individualized care. Now at the registration, we are doing an SF36 score, a little bit too fast there, yeah, up, back, yeah. And our aim is to repeat this score every 3 to 6 months. I have to admit that due to the pandemic, everything has been slowed down, and we have not been able to do all we wanted to do for various reasons. We also have Fitbit. We have the possibility to register by Fitbit, heart rate variability, sleep, respiratory rate, oxygen saturation, how many steps and calories the person is consuming every day. So we want to have some basic statistics and see how this changes during the stay. And the stay is a long-term stay for months and maybe some years. We think that is needed. Next slide, please. So this is what it looks like. This is for the staff, and also we can have relatives here. It's a very nice and quite new and modern buildings. Next. So what do we offer? Well, as I mentioned, we are having an individualized approach, and we also have we have a large kitchen in this institution, so we can individualize the diet with different diet needs. And we have a very active ME doctor there, a long experience, so he offers to all the patients Q10 every day plus NADH. There's some data indicating this is good for ME patients. He also uses high dose of B12 orally every day. And then we give oral rehydration solution with GEM, call it 3 bags in 1 liter water orally. And patient had to drink this instead of having a saline infusion, which we know is good for some of these patients. So twice a week they get this regime. And next slide, please. And some also offered low dose Naltrexone, which in some patients seems to be beneficial. And a new assessment after 8 to 12 weeks is applied. This is based on a Finnish study. Abilify has also been offered to some patients, very low doses, up to 5 milligram after 2 weeks. And we're also planning now, we heard that, and we got some data about B1 timing, high doses, which could be good for ME patients. And some patients also want to try gamma globulin. And we will offer that after an individual assessment. Now, the advantage with this is that many of these patients, they have tried everything at home, but they haven't tried it combined in this package. Next slide, please. So what are our preliminary results? They're very, very preliminary. Well, actually, out of the 11 patients we have treated, 2 of them, 2 young girls who were bedridden for many years, they recovered quite quickly and are already back home. One person went back home because she had to fund this by private means. So after 3 months, she went home. But what we feel, what we think, but this is so preliminary, I hardly dare to say it, but this is within this group. There is a general trend that all the remaining patients are slowly improving. And we think this is extremely encouraging. And some of these patients are among the most severely ill ME patients in Norway. I've visited most of, or not most, but many of the ME patients in Norway in their homes. And some of these patients here are among the most severely ill patients. So next slide, please. So this was my very brief presentation, and as I said, we shall overcome. Thank you very much.
Thank you very much for your interesting presentation, Ola. And we have a question for you, which may be of very great interest. You said that 2 people recovered. What does it mean by recovering? Are they completely healthy or just partly improved?
Yeah, it was, you know, this was during the pandemic. I couldn't visit this institution for several months myself. So these were 2 young women in their 20s. They were bedridden for a long time. We classified them as very severe ill ME persons. And after a few weeks, they recovered and they sat up, and then they walked out of the room. And after another 3 or 4 months, both of them had recovered, so they went home. Now, what we have to do, also, we have to follow up, of course, these patients. So we have to, this is so new that, and this was, for me, it was unexpected because I hadn't expected that. And we have been wondering why. I mean, there are only 2 patients, but still, I think it's quite interesting. Well, I think we are really respecting these patients. They don't get all these PEM episodes, which many of the ME patients have because of a lot of stress and misunderstandings and fightings, and maybe high doses of vitamins combined with low dose Naltrexone has some effects. So we have to do this in a more scientific way, and this is my obligation to do that. And we want to present this, and we also hope that we can do studies with other European countries so we can get a bigger material, because after all, we have only 12 patients.
Thank you very much. Are there more questions from the panelists? Well, if not, I was just curious. You mentioned several ways of intervention. Do you combine all these at the same time, or do you use sequence?
Yeah, that's what I'm not a medical responsible person, but the doctor there, who has a long experience with ME, he's combining this. And by the way, since we talk about that, if any one of you in the panel or listening to this have any suggestions how to do this, or do it in a better way, we'll be very grateful to get inputs from you.
Another question is, can you say something more about the admission processes? Who will get access to these? Who pays for them, and so on? Yeah.
Well, they have to apply, and they do that through their general practitioner. And most counties are now paying for this, but they have to approve it. And so we had some problems that the county, this is a new, and they didn't want to pay for it, and it's very expensive for them to pay it by themselves. Still, a few patients have done that. So we have actually discussed this already with the members of the parliament, so that this can be funded by the Norwegian the public health system. And I think that when people learn about this possibility, I think it will be easier to get it funded. So we get it funded, and we have a committee who's now we have a lot of applications. We have too many applications because rumors about this it's around, and all MA patients all over Norway. So we already found out we have to establish more of the same kind, maybe in all regions in Norway. And we were worried about the transport, because the long distances in Norway, but so far the transport by ambulance for several hours we have been quite successful.
Okay, thank you very much. And I think we have covered the questions. One question is, well, can you accept patients from other countries?
Yeah, actually we have received applications from other countries, all the way from Pakistan and from neighboring countries, Sweden. And so far we cannot do that, but we want and we wish that we can do that. And maybe in the future we will be able to accept also patients from other countries. But as the capacity is quite low. But we're happy if we can help patients also in Sweden, for instance.
Professor Markku Partonen is a member of the European ME research group, EMERGE. He currently works at the Helsinki Sleep Clinic, Terveystalo Healthcare in Helsinki, Finland. His current topics include narcolepsy, sleep apnea, ME, CFS, COVID-19, long COVID, insomnia and disorders of autonomic nervous system. Today Professor Partonen presents on a recent international study on long COVID and explores similarities with ME, CFS.
So I am going to talk about long COVID and similarities with ME. So I'm working in Helsinki, and if you are interested on this international collaboration, I advise you to write, for example, ICOS and Helsinki, and you should go to this internet page where you can see more information about this international collaboration. So it is an international collaboration. We currently have 18 different countries, one of the basic ideas was here to harmonize the questions and the items that we are using in studies of COVID and long COVID. So we use exactly the same measures in all countries. They have been cross-translated and all measures are valid and measures. First, some small things to remember about the definition, and I think these are important also what we heard from SNOMED. So definition of health according to WHO is a state of complete physical, mental and social well-being, not merely the absence of disease of infirmity. This definition is very poor because if we look things as they are, nobody in the world is healthy. All people are ill because nobody is perfectly ill. For example, here I can see that some of us have eyeglasses, and if we hear eyewear, we are not healthy, of course, because our sight is not perfect. So a better definition might be the definition of Seedhouse, a philosophist in the UK. And according to Seedhouse, health is an equivalent to the state of the set of conditions which fulfill or enable a person to work to fulfill his or her realistic social and biological potential. So a person may be healthy even if he or she has some disease. I think this is important for ME as well. So we may have patients with ME who feel that they are healthy, and we may have patients with ME who are not healthy. And a person may be 10% healthy, or a person may be 50% healthy, or 100% healthy, which is very rare. Another issue which is important to make a discrimination is the terms of disease, illness, sickness, disorder, and medically unexplained symptoms. Disease has a biological definition and a biological marker. We know the pathophysiology. Then we have illness. Sickness is the term that people have social insurance. And then we have disorder, which is not an illness or a disease. Patients with ME are ill, and they do not necessarily have a disease. So then another issue is the term of structural and functional illnesses. A structural disease is a disease which can be related to a hardware problem in a computer. And if there is a hardware problem, you should change the hardware, you should change the computer or the screen by surgical methods or something like that. Or by medication, if it's, for example, streptococcal infection is a structural disease because we know that it is a streptococcus, and when we use antibiotics, we can cure it. Then we have functional illnesses, and functional illnesses can be related to a programming error, computer virus, a bug in the program, so it is a software problem. The reasons for functional illnesses may be cyber attacks, computer virus, computer worm, a Trojan, a Knox or a trauma. So this means that ME CFS is a functional illness, but then there is a misunderstanding that functional means that it is always psychiatric. That is not true. A functional illness may as well be somatic or biological. And ME is a biological functional illness, or a somatic functional, or a physical functional illness. If somebody has a mental developmental disease, a genetic disease, or a primary neurological or psychiatric disease, such like schizophrenia, the problem is in the processor. So the processor does not function, and that is not an easy problem to solve, of course. We also have the questions of fatigue, sleepiness, and tiredness. We already discussed about those. We just have to remember that those are different. So tiredness is not synonymous to fatigue, which is not synonymous to sleepiness. So it is very important that we make a distinguish those different terms: fatigue, sleepiness, and tiredness. So ME/CFS is a physical illness, and long COVID is also a physical illness. So they are both physical illnesses. Like a misunderstanding we have just discussed in our collaboration, for example, about psychiatric diseases. And for example, is depression a psychiatric disease, syndrome, or a psychiatric illness? We can say that depression does not have exact pathophysiology. We don't know the reasons for depression. There is usually nothing to operate in depression. Same is true for anxiety. And for this reason, both depression and anxiety are functional psychiatric illnesses. So now when we go to post-viral fatigue syndrome, or ME, in ICD-11 of the WHO, the code is 8E47, and you can see that it includes ME, and it includes also the term chronic fatigue syndrome. But simple fatigue is not included in this diagnostic code. Some investigators, for example, in Denmark, have said that well, patients with chronic fatigue syndrome have a bodily distress disorder. That is not true. As you can see in the exclusions, for example, post-viral fatigue syndrome and ME are exclusions for this bodily distress disorder of the WHO. So those who are claiming on this diagnosis are, of course, totally wrong. So what is long COVID? We have a definition of WHO, which was given in October 2021. And the definition was based on a Delphi panel group discussions and votings. And the conclusions was that there should be a history of COVID infection. The laboratory confirmation is not necessary because people may not have had antigen testing or PCR. So, but there is like a historical infection, but the laboratory confirmation is not necessary. Then the symptoms should have started within 3 months from the onset of the COVID. And their duration should be at least 2 months. And if those are fulfilled, we can call it long COVID. According to the WHO, the main symptoms are cognitive dysfunction, fatigue, and shortness of breath. I will come to this because it seems that this is not perhaps quite true. And then what about the minimum number of symptoms? It sees, according to WHO, 1 symptom is enough, but when we have done further studies, it seems that we should use at least 3 concomitant symptoms. They can start be like in different clusters. They may be fluctuating, new onset, persistent, or relapsing. And then the symptoms cannot be explained by an alternative diagnosis. So then we go to the definition, which is the one that I just told. WHO notes that a separate definition may be applicable for children. So if we look, what are the symptoms? A lot of different symptoms. This is from one paper published in the Nature 2021. And as you can see, really many symptoms. But if you look at the most common symptoms, we have fatigue, headache, attention problem, and so on, which are the same as we often find in ME. In our collaborative work, we have done studies in different countries. In this study, we had 14 different countries, and we found that most symptoms increased during the pandemic, either related to the viral infection or also the pandemic. The traumatic events of the pandemic also could cause some symptoms. And here are, excuse me, here are the recent yet not published results. We aim to publish them, of course, and have now submitted them. So if you look at the different symptoms of long COVID, so all these symptoms fulfill the WHO criteria. And the bars represent different severity classes of the COVID. So in black, people without COVID, and no symptoms. Dark red here with mild COVID. Blue, moderate COVID. Moderate COVID means that they needed to take some medications, but they were not yet in hospital. And then severe and life-threatening meant that they were treated in a hospital, and life-threatening means that they were treated in an internal care, ICU, intensive care unit. The most common symptom of long COVID is fatigue. Next common is difficulties falling asleep or difficulties maintaining sleep. Third, brain fog and troubles of memory. Fourth, PEM, symptoms of PEM. 5, excessive daytime sleepiness. Then we have joint and muscle pains, shortness of breath, problems of sweating, loss of smell, cardiac palpitation, orthostatic dizziness, tachycardia, headache, and so on. So now if we look at the most common symptoms, they are exactly the same as what we found in ME patients. There are some differences between countries. Previously today, there was a question that should we use different criteria in different countries. My answer is that absolutely not. If we have used different criteria, we can never compare the symptoms, and we cannot do any epidemiological studies. So we need to use exactly the same criteria in all countries. If there are differences, the differences can then be explained by cultural effects and so on, but the criteria must be the same. So here, if you look for the prevalence of symptoms of fatigue in controls and also in patients with post-COVID, there are differences. And interestingly, in Finland, 76% of patients who have had COVID have developed also long COVID. While in the USA, only 9% had developed long COVID. Also in Japan, 15%. In Portugal, 23%. In Norway, 46% of the COVID patients developed long COVID. In Italy, 54%. In Sweden, 32%. So there are differences between different countries, and it is interesting to see, and we are going to study that what is the reason for these country-wise differences in the prevalence and in the occurrence and incidence of long COVID. So if you look at the different symptoms and compare the symptoms of long COVID to ME, they are practically the same. Of course, we do not know yet that how many patients have developed ME due to coronavirus. We don't know this. And we don't know how many have developed ME because of the coronavirus. The reason is that if somebody now develops symptoms of fatigue, most certainly they will be diagnosed as long COVID patients and not as ME patients. Which causes, of course, also a bias. Looking for the pathophysiology of long COVID, here are different theories. I do not go to them separately, but when you look at them, they are actually almost the same as different theories and of pathophysiology in ME. In fact, it is interesting that for the pathophysiology, if you look how many studies on pathophysiology were published on ME before the pandemic, I can say that perhaps we had one new study published per month, sometimes a few studies per month. Now, during the COVID times, we have at least 10 new studies each week. Sometimes we have several studies each day. So when I have collected pathophysiology of long COVID, I already have in my personal bibliography more than 3,000 publications on long COVID, but very few studies on the pathophysiology of ME, which is interesting. And before the pandemic, people, you know, we all know the history of many doctors and researchers did not believe in ME, but now the same doctors are saying that ME, that long COVID is a physical illness. There are some very new results which are not nice. For example, even a mild COVID-19 may damage brains at least temporarily. So they are very new studies of the UK Biobank, and this is very alarming, of course. And they have done prospective studies, so they have done studies before having COVID and after COVID, and shown that it is really the COVID which causes damage to the brain. Now, of course, we can ask that, does the same happen in ME, or could some of these be actually ME? And my answer is that yes, these patients fulfill also the criteria of ME, even that the diagnosis is COVID and long COVID. Another issue which is interesting, that during the in ME and also in narcolepsy, there have been studies, for example, in the Columbia University, that the virus may go via olfactory nerve directly to the brain, but those studies were not, you know, widely cited. But now we have a new study showing that the same thing happens with the coronavirus. So the coronavirus may travel through the olfactory nerve directly to the brain areas. So they travel through the nose, and here are different areas in the brain, and you can find them in the medulla oblongata, also in the cornea, and many other places. Another entry way is through the gut, from the gut via the vagal nerve. So that is also a possibility. Also, the virus may travel by the systemic circulation and then cross the blood-brain barrier. Exactly the same mechanisms which have been postulated in ME. Here is a recent study, a very nice review in Science by Spudihan and Nat. And if we look, so there is limited information that it would be direct viral attack to the brain. It can be by damage to the microglial cells. The cytokine theories are there and the antibody theories are there. There is also plenty of data that the brain symptoms may be caused by clotting in the blood vessel or by endothelial function disorder. What finally causes neural injury is not yet known. So what about the long COVID prognosis? This is interesting because the prognosis of long COVID seems to be excellent in children and adolescents. So 95 to 100% recover, meaning that they go back to school. In general, in adults combined with children, over 80% are recovering and ameliorating significantly within 3 to 12 months. And this recovering means that they go back to work and they go back to school, either totally healthy or almost healthy. But I go back to the definition of health. So a patient may be, a subject may be healthy even if there is still something left. So we do not need to be 100% biologically cured in order to be healthy. 5 to 10% have symptoms for more than 18 months. And it seems that a small portion, perhaps 5%, may develop chronic symptoms or chronic illness. And these are the patients who probably develop ME, chronic ME. But is the prognosis good? We really don't know. If we look, for example, the alarming recent studies of the UK Biobank. So is this a new disease? No, it is not. but long COVID seems to be a new type of post-viral fatigue syndrome. So in a way, it's like a new phenotype of ME. Here we have the diagnostic codes for long COVID U09.9. For post-viral fatigue syndrome, or ME, the code in ICD-10 is 393.3. In ICD-11, the diagnostic code for post-viral fatigue syndrome and ME is 8E49. In ICD-11, there is also a code for post-COVID condition, and then there is the code for post-viral fatigue syndrome. It is interesting to hear, or I also want to hear from Ian Green about how to use the diagnostic codes, because if we only use the code RA02 and we do not use this code, we will think that it is totally separate from ME, which probably is not true, because they are both forms of post-viral fatigue syndrome. So is it new? No, it is not. If we go to the war already in 1871, we had similar symptoms related to war. It may have been the war trauma, or it may have been some viral diseases that were spread during the war. We don't know that. Same was true in the World War I, and again, we don't know whether it was a virus or whether, and what was due to the traumatic event of the war. And then we had a problem. We had the Akureyri disease in Iceland. We have had several different outbursts and clusters of ME in the 50s, in the 60s, in the 70s, in the 80s, in the recent years. Now, if we make a question, if we had similar long COVID patients without knowledge of COVID, which could be the likely diagnosis? And I would guess that many patients would have got a diagnosis of a somatoformic syndrome, dissociative symptoms, medically unexplained symptoms, psychiatric functional disorders, and perhaps some patients may have got the diagnosis of ME. But because we had the knowledge of COVID, all those patients are diagnosed by the term long COVID and not, for example, ME. Here you can see just the relationships of the post-COVID dysautonomic. So we have different symptoms, exactly the same as in ME. We have autoimmune pathology. We can look at different autoantibodies as in ME right now, for example, for the autonomic nervous system. What are the tests that we can use in long COVID and ME? Exactly the same. And as concerns treatment, again, the same treatment as in ME, including perhaps pacing, avoiding of triggers, increased water and salt intake, blood volume expanders, beta blockers, sympatholytic drugs, compression garments, and vasoconstriction. So exactly the same medications as in ME. So in conclusion, the most severe forms of long COVID is the post-ICU patients, where the COVID-19 has been very, very severe. That differs from ME because they really have a lot of problems in the lungs. They have a lung fibrosis and so on, which is not typical for ME. But long COVID after mild and moderate COVID-19, or without knowledge of prior COVID-19, is post-viral fatigue syndrome. So could we use the diagnostic criteria of ME, for example, the international consensus criteria, to diagnose LC? In my opinion, we could use them, but of course that is not yet agreed all over the world. What is the proper diagnostic code for long COVID? And I would suggest that we use both those codes. So we use G93.3 and we use at the same time the code U09.9. In that way, we know that the long COVID is a form of post-viral fatigue, and it allows us to do epidemiological studies in the future. the hypothesis, of course, is that coronavirus may trigger both long COVID and it may also trigger ME. Interestingly, and this is something good, is that the research on long COVID helps us to understand also ME, and it also probably helps us to find new treatments for ME. And the issue is that as concerns drugs, most probably the drugs and treatments for long COVID may also work in ME. And thank you very much. And here are some publications that we have published on long COVID and also relations of long COVID and ME. Thank you very much.
Thank you very much, Marco, and for an interesting and perhaps demanding presentation concerning the relationship between the corona pandemic and ME. So, well, let us open for questions or comments. I can see in the Q&A that there is more of a comment, and perhaps you could say a little more about that, Marco, who point out that functional illness should not be used for ME/CFS because of it will confuse the situation and in some way promote that it's a psychological or mental disease. What do you say about that?
Yes, exactly. This is really a problem. I also, in a general public or with other doctors, if we use the term functional illness, many doctors, I would say that the majority of physicians will misunderstand it because the functional disease, functional illness is not correctly understood. It will take a long time before that is the case. So now, of course, should we not use that term is a problem. But if we don't use that term, it is like putting our heads, into a bush like a share, like a rabbit. So I think that we should just, educate people that what means somatic or physical disease, physical illness, even if it is functional. So I think we have to educate that functional does not mean psychiatric. But if we don't use that term, it means that we should use a knife. We can cure ME by surgical operations. And I don't know a single patient with ME who has been cured by an orthoped or by a neurosurgeon.
Yeah, surely. Okay. Are there more comments or questions from the panelists? If not, I have a question for you, Marco.
Yes.
You have been very active in the field comparing ME and long-term COVID. Today, with the present knowledge, would you say that there is a proof that long COVID is not ME?
No, and this is, as I told, that I am working, also in a task group of long COVID. And, it's very difficult for me because there are experts who 5 years ago were almost, laughing also at me that, Mark, what are you doing? You are talking about this ME, what is this? And now the same experts say that, well, this is physical. So, I think it's a little bit, people have totally changed their mind. So, in my opinion, long COVID mostly is like a new type of ME where the causative agent is coronavirus. That is my opinion.
Okay.
But of course, the old people do not accept it because they think that it's a totally new one.
Yes, I know that. Yes, thank you very much. Well, so we can see that this is actually, as I said, just a new form of ME, and that is started by this coronavirus, such as other viruses done it before.
Yes.
So, from that point of view, it's nothing especially new. But as you mentioned, it's very interesting to see that prominent physicians can change their mind sometimes when they realize that this serious pandemic has also these effects that are, well, more or less or identical to ME.
Yes, and I think it will happen in that way that prominent scientists, you know, in the long term, after 1 or 2 or 3 years, they will understand that, my God, is this the same ME that some others have talked before? So they will realize, but it will take time. Right now, you know, it's difficult for many people to change their minds.
It's well known. It's well known that it's difficult to change your mind. Well, okay. Thank you very much, Marco. And as far as I can see, I will check if we have Monica.
Yes, we have one more question from.
Yeah, we have one
Franco.
concerning Lyme's disease. Would you like to comment about that, Marco?
Yeah, yes. So Lyme's disease or chronic borreliosis. So this is also interesting. So is that ME? Again, we could say that you may have ME where the causative agent has been Borrelia. So that is a possibility as well. And that is, again, one problem that patients with, some patients may have like a diagnosis of chronic Lyme's disease, or long-term Lyme's disease, and not a diagnosis of ME. So for me, ME, the causative agent of ME may be, a virus, it may be perhaps a streptococcus. Now, for example, in long COVID, there is a theory that actually long COVID may be due to Epstein-Barr virus, so that it's the Epstein-Barr virus which is actually launching long COVID. And if we go back in the history, there are quite a lot of evidence and studies showing that Epstein-Barr is one causative agent for ME.
Yeah, it's well known. Yeah. Okay, time is running on, and I think it's time to sum up a little of this symposia.
Recently, a report was produced based on last year's EMEA Nordic Networks mini-survey and online meeting, arranged by EMEA Finland, the Medical Association of ME, CFS in Finland. The report maps healthcare and research in the Nordic region. In the year of Finland's presidency 2022, the Nordic Council celebrates its 70th anniversary, which provides an excellent opportunity to find ways of working together that can make Nordic cooperation even more effective. The proposition will be advanced to the Nordic Council of Ministers. The number of ME patients is estimated to double in the wake of the COVID-19 pandemic, and developing effective approaches to long COVID and ME are now proposed as part of joint long-term strategic goals, with EMEA, Emerge and the European Clinicians Group, EMECC, mentioned in this context. More details, including the Nordic report, will be made available following this meeting on the EMEA website. As mentioned previously, EMEA is arranging additional events this year to continue looking for solutions to issues with ME, CFS. EMEA will this year seek to monitor the status of ME, CFS in Europe and bring together stakeholders from across Europe, and from around the world, to establish data and influence policymaking. More details will be provided on our website following this meeting. Thank you everybody for joining this webinar. We would like to thank our speakers and panelists for their time and input to the meeting today. References to information in this webinar may be found at the links on this slide.